In a consultation room in Atlanta, Georgia, in the spring of 1991, a woman named Pam Reynolds sat in a chair and listened to a neurologist say words she had not expected to hear. She was 35 years old. She was a professional singer-songwriter working out of Atlanta, writing and recording and performing with the particular discipline that sustains a life built around music. The symptoms had been coming on gradually: dizziness at first, then difficulty finding words, then a heaviness in her limbs that did not lift the way ordinary fatigue lifts. She had gone to her doctor the way a person goes when something is not quite right, but not yet alarming. The doctor had referred her. The referral had led to imaging. The imaging had led to this room, and to this conversation, and to the words giant basilar artery aneurysm, spoken in the particular register that physicians use when the news is serious and the patient is sitting right there in front of them, trying to take it in. The scan was on a light board on the wall. The neurologist had pointed to a specific location within the image, a region deep inside the skull, near the base of the brain, where an artery called the basilar artery runs upward toward the brainstem. What the scan showed at that location was a ballooning of the arterial wall, a swelling where the vessel had grown thin and distended under pressure until it had formed a rounded protrusion approximately 4.5 centimeters across at its widest point. The number was precise. It had been measured. 4.5 centimeters is not large in most contexts, but in the context of a space as enclosed and as consequential as the interior of a human skull, it is very large indeed. It was the size, roughly, of a walnut. It was sitting in a place where very little space existed for anything that was not supposed to be there. Pam would have looked at the scan the way most people look at medical images of their own interior, trying to locate herself inside the abstraction, trying to make the gray shapes on the light board correspond to something felt, something known from the inside. The ballooned wall of the aneurysm would have appeared as a soft, rounded shadow against the deeper structures around it. The neurologist would have traced its outline, identified the vessel, described the anatomy. A basilar artery aneurysm at that location, near the brainstem, is positioned among structures that govern some of the most fundamental functions of the body: breathing, heart rate, the basic regulation of consciousness itself. The proximity is not incidental. It is the thing that makes an aneurysm at that location different from an aneurysm elsewhere. The margin between the swollen vessel wall and the structures around it was measured in millimeters. The diagnosis was what it was. The scan did not allow for reinterpretation. An aneurysm of that size, at that location, in an arterial wall that had already been stretched to its current dimensions, carries a known risk of rupture. A ruptured basilar artery aneurysm near the brainstem is in most cases not survivable. The neurologist would have communicated this with care, but the care would not have changed the substance of what was being communicated. Pam Reynolds, a healthy woman in her mid-30s, a working musician in Atlanta, had a structure inside her skull that, if it failed, would very likely kill her, and that, by virtue of its position and its size, could fail without warning. The question that follows a diagnosis of this kind is whether anything can be done. Pam's case was referred to specialists. The geometry of the aneurysm's location at the junction of the basilar artery, close against the brainstem, deep within the posterior fossa at the base of the skull, made it inaccessible by conventional neurosurgical approaches. Standard operative techniques for aneurysm repair require access to the vessel, the placement of a clip across the neck of the aneurysm to seal it from the circulation. To reach the basilar artery near the brainstem by a conventional route, A surgeon would have to work through or around structures of enormous neurological importance, and the act of reaching the aneurysm would likely cause hemorrhage or damage that would not be compatible with survival. The neurosurgeons consulted in Atlanta were frank about this. The location was one of the most difficult in the entire discipline of cerebrovascular surgery. Conventional intervention was not an option that could be responsibly offered. It was in this context that the name Robert Spetzler came up. Robert F. Spetzler was, by 1991, one of the most respected neurosurgeons in the world. His particular area of expertise was complex cerebrovascular procedures, the category of surgery that addresses the blood vessels of the brain and brain stem in cases that other surgeons considered inoperable. He was based at the Barrow Neurological Institute in Phoenix, Arizona, a major academic and clinical facility that had become, under Spetzler's influence, one of the leading centers for neurovascular surgery anywhere. If anyone had a method that could address an aneurysm at Pam's location, the people in Atlanta believed it was Spetzler. The Barrow Neurological Institute in Phoenix sits in the desert heat of central Arizona, a large clinical building set against the wide, flat light of the Southwest. Phoenix in the early 1990s was already a substantial city, spreading across the valley floor in the particular way that desert cities spread, low and wide, the streets long and straight, the sky above them enormous. The institute itself had the look and feel of a place where difficult work was done seriously. Long corridors, quiet waiting areas, the particular hush of an institution where the conversations happening behind closed doors carry significant weight. Spetzler had built a program there that attracted cases from across the country and beyond, patients whose conditions had been deemed inoperable elsewhere and who arrived in Phoenix carrying the particular mixture of hope and apprehension that comes with being told that the most difficult case is exactly the kind of case this doctor takes. Pam and her family made the decision to travel to Phoenix and consult with Spetzler. The consultation would have involved everything a consultation of that kind involves: reviewing the imaging, discussing the anatomy of the aneurysm, going through the medical history, considering the options. Spetzler would have approached the case with the systematic care of a surgeon who has spent decades thinking through problems that do not yield to standard approaches. He would have studied the scans. He would have considered the dimensions of the aneurysm, the exact location of its neck, the relationship between its walls and the surrounding anatomy. And he would have arrived at a conclusion that, while not unexpected given everything that had already been said in Atlanta, would have required a particular kind of stillness to hear. The aneurysm could not be safely accessed while blood was flowing through it. It could not be safely accessed while it was pressurized. A pressurized basilar artery aneurysm at the brainstem, approached with standard surgical tools through any available corridor, would almost certainly rupture during the approach, and a rupture at that location in an open surgical field would be catastrophic. The taut, inflated walls of the aneurysm made it rigid and fragile simultaneously. Any manipulation of a structure that size, carrying arterial pressure in a space that confined, carried a probability of death on the table that Spetzler described without softening. He was direct about this. He was not a surgeon who obscured difficulty. The risk of conventional intervention, he told Pam and her family, was extremely high, higher than most families are accustomed to hearing stated plainly across a desk. What Spetzler proposed instead was something different. It was a procedure that had been developed for exactly this category of problem: aneurysms that were anatomically inaccessible under normal circulatory conditions, Situations in which the presence of blood flow and blood pressure in the surgical field made safe repair impossible. The procedure is known in clinical and case literature as hypothermic cardiac arrest, and sometimes referred to in the context of this particular case as Operation Standstill. The name gives some sense of what it involves. The idea is this: if the aneurysm is dangerous because it is pressurized and blood-filled, then the solution is to remove the pressure and the blood. The way to do that is to stop the heart. Spetzler's hands were on the desk when he explained this. The explanation was methodical. It did not rush toward the most dramatic part of the proposal. It built toward it through the logic that makes the procedure comprehensible. The anatomy, the problem, the reason conventional approaches fail, the mechanical solution that hypothermic cardiac arrest provides. But the conclusion of the explanation was, however it was framed, this: the procedure Spetzler was recommending would require the complete cessation of Pam Reynolds' heartbeat. Her heart would be stopped, her blood would be cooled and then drained from her cranial cavity. Her brain would be without circulation. Her body would be brought to a temperature so low that the cells of her nervous system would enter a state of suspended metabolic activity, alive in the technical sense that no irreversible damage would be occurring, but operating at so slow a rate that even the EEG, the instrument that records the electrical activity of the brain's cortex, would show nothing, a flat line. The physiology behind this is specific and documented. When the human body is cooled to a sufficiently low temperature, the metabolic requirements of the brain cells decrease dramatically. At normal body temperature, the brain requires continuous oxygen delivery. A deprivation of oxygen for more than a few minutes begins to cause irreversible cellular damage. But a brain that has been cooled deeply enough requires far less oxygen, and for a limited window of time can tolerate an absence of circulation that would be catastrophic at normal temperature. That window is narrow. It is measured in minutes, not hours. But within that window, a surgeon can work in a field that is bloodless and still, without the pressurized arterial walls that make safe access to a basilar aneurysm otherwise impossible. The procedure requires precision at every stage. The cooling must be gradual enough to prevent cellular trauma from temperature shock. The target temperature must be reached before the heart is stopped, not after. The standstill phase must be timed from the moment of cardiac arrest. The surgical work must be completed, the aneurysm clipped and secured within the window the cooling has provided. Then the blood must be reintroduced, the heart restarted, the temperature raised slowly back toward normal. Each of these stages carries its own risks and its own requirements for coordinated expertise. It is not a procedure that one surgeon can perform alone. It demands, at a minimum, a neurosurgical team, a cardiac surgery team, and a perfusionist operating the heart-lung bypass machine that manages the blood during the cooling and rewarming phases. The teams must be synchronized. The timing must be tracked continuously. Spetzler had performed procedures of this kind before. The Barrow Neurological Institute had the infrastructure, the personnel, the equipment, and the experience to support it. The hypothermic cardiac arrest approach, while extreme by any measure, was within the range of what Spetzler's program could offer. It was not experimental in the sense of being untested. It had been used in documented cases, and its physiological basis was understood. It was extreme in the sense that it is used only when there is no other choice, when the alternative is not a conventional surgery with manageable risk, but the near certainty of death on the table from a procedure that has no reasonable chance of success. The choice Pam Reynolds was facing then was not between a dangerous surgery and a safe one. It was between the danger of the standstill procedure and the danger of doing nothing. The aneurysm, at its size and location, carried the ongoing risk of rupture. An unrepaired aneurysm of that kind is not a stable condition. It may hold for months, it may hold for years, or it may not hold at all. The wall is thin. The pressure inside a basilar artery is considerable. Every day that passes with that structure intact is a day on which the outcome remains unknown. Pam returned to Atlanta. She had documentation from Spetzler's team, notes and referral materials, and the name of the procedure written down in terms she could share with her own doctors and her family. Back at her kitchen table in Atlanta, with the particular quality of quiet that a house has when its occupant has just received news that reorganizes everything, she would have sat with a notepad and the name Robert Spetzler, Barrow Neurological Institute, Phoenix, written at the top of a page. The rest of the page would have been for working through what she had been told and what it meant. The notes that people make in that kind of situation are not for anyone else. They are the written form of trying to hold something in place long enough to understand it. The singer-songwriter in her would not have disappeared during any of this. The capacity to observe, to notice, to file away the texture of an experience that does not switch off because a person has been given difficult medical information. It simply records the consultation room, the light board, the scan, the hands on the desk. The way the word aneurysm sounded when it was said not as a term from a medical documentary, but as a description of something living inside her own skull. The way cardiac arrest sounded when it was spoken not as a crisis, but as a planned intervention, a deliberate act performed at a specific time by specific people in a specific room. The procedure Spetzler described would require Pam to choose it. It was not something that would be done to her without her understanding and consent. She would need to decide that the standstill procedure, with all its attendant risk and all the strangeness of what it involved, was the path she was willing to take. Spetzler had been honest with her about the risk of not acting. He had been equally honest about the risk of the procedure itself. Deep hypothermic cardiac arrest carried risks of its own, neurological complications from the cooling, risks associated with cardiac restart, the possibility that the clipping of the aneurysm would not be achievable within the available window, even once access was gained. No guarantees were offered. What was offered was a surgeon's honest assessment that this procedure provided the best available chance of a successful outcome. There are cases in medicine that sit at the edge of what the discipline has learned to do, cases where the available technique is so extreme, so far from anything that would be recommended in less urgent circumstances, that even the people performing it carry a particular awareness of the distance between ordinary surgery and what they are about to attempt. Hypothermic cardiac arrest is one of those techniques. It emerged from the need created by exactly the category of problem Pam Reynolds presented, an anatomical situation in which the only surgical access requires conditions that the living body cannot otherwise provide. The logic is not difficult to follow, but the logic, once followed, arrives at something that is genuinely strange to sit with. The procedure proposed for Pam Reynolds required that she be in every clinical and physiological sense stopped. Her heart would not be beating, her blood would not be circulating, her brain's electrical activity would not be detectable, her body temperature would be far below the range compatible with normal life. The instruments designed to measure the signs of life would, during the standstill phase, record nothing. The monitors that track heart rhythm would show a flat line. The electroencephalogram that records the brain's cortical activity would show a flat line. The monitoring equipment that measures the brainstem's responses to sound would show, by design, the same absence. Every conventional indicator that a clinician uses to determine whether a patient is alive would, for a period measured in minutes, report the same thing. And in that state, Robert Spetzler and his team intended to open Pam Reynolds' skull, access the basilar artery at the base of her brainstem, clip the neck of a 4.5 centimeter aneurysm, confirm the clip's placement, and then restore her to circulation, temperature, and heartbeat. The whole procedure, the cooling, the standstill, the clipping, the rewarming, the restart, would take hours. The standstill phase itself would be a fraction of that total time, but it was the fraction on which everything depended. Pam Reynolds made the decision to go forward. She was a person who had, by 1991, spent years making professional decisions in circumstances that required both courage and clear-headedness. The decisions a working musician makes about their art and their livelihood, the decisions a person makes when they are building a life around something they care about. She was not naive about risk. She was not, by the accounts that survive of her, a person given to either recklessness or passivity. She had looked at the information Spetzler and his team had provided. She had understood, as well as a non-physician can understand, what the procedure involved and what it asked of her, and she had decided. The arrangements were made for the surgery to be performed at the Barrow Neurological Institute in Phoenix. Spetzler's team would handle the neurosurgical component. A separate cardiac surgery team would manage the bypass and the cardiac arrest and restart phases. A perfusionist would operate the heart-lung machine throughout the procedure, monitoring blood gases and temperature and the slow transition between states. The operating room would be staffed by 8 or more people, each with a specific role in a procedure that required coordination across disciplines in a way that most surgeries do not. Atlanta, in the weeks before Pam traveled to Phoenix, would have had its ordinary spring quality, the particular warmth that arrives in Georgia in that season, the way the city continues its daily rhythms, regardless of what any one person is carrying. She would have gone on working, or tried to. She would have had conversations with people she was close to, conversations about what was happening, what was planned, what the outcomes might be. The music she had been working on would have continued to exist in its own state of incompletion. A singer-songwriter does not stop hearing melodies or carrying lines in her head because she has been told her brain contains a structure that could kill her. The two things would have simply coexisted, the way difficult and ordinary things always coexist in a life that is still being lived. The preparation for a surgery of this complexity involves more than scheduling. It involves detailed preoperative assessment, cardiac evaluation, neurological baseline testing, assessment of the blood vessels that would be used for the bypass cannulas, review of the imaging to plan the surgical approach. Spetzler's team would have gone through all of this systematically. The aneurysm's geometry would have been studied from multiple angles, the access route planned in detail, the instruments selected. The cardiac surgery team would have mapped the approach to the bypass. The perfusionist would have prepared the heart-lung machine and its circuits. The Barrow Neurological Institute, by the time Pam Reynolds arrived there for her surgery, had been built into exactly the kind of institution that could support a procedure of that difficulty. The corridors of a major academic medical center have a particular quality at any hour, the particular organized motion of a place where a great deal is happening simultaneously, where the individual cases that make up a day's work represent the full range of what medicine knows how to do. At the edges, some of what it is still learning. The Institute had seen difficult cases before. It would see difficult cases after. But the procedure planned for Pam Reynolds was among the most extreme in the existing repertoire, not because hypothermic cardiac arrest was new, but because the combination of that approach with the specific anatomy of her aneurysm placed the surgery at a point where the available technique was being used at the full extent of what it could reasonably offer. The question of what happens to a person during the standstill phase of a procedure like this is one that the surgical team would not have been focused on in terms of conscious experience. Their attention during the standstill phase would have been directed entirely outward, toward the surgical field, the temperature logs, the timer, the instruments, the condition of the aneurysm, the placement of the clip. The monitors would have been reading flat because the procedure required them to read flat. The absence of measurable brain activity was not a complication, it was the intended state. The deep hypothermic cooling was designed specifically to produce cortical silence, to reduce the brain's metabolic activity to a level at which the cells could survive the absence of blood flow for the duration of the surgical work. The flat EEG was, from the surgical team's perspective, confirmation that the procedure was proceeding as planned. What a patient might experience during a state of that kind, what, if anything, occurs in the space between the last detectable brain signal and the first detectable brain signal on the other side of the standstill, is not a question that surgical teams in 1991 were formally equipped to address. It was not part of the operative record. It was not something the instruments in the room were designed to capture. The instruments in the room were designed to measure the physiological parameters that the surgical team needed to monitor. They were designed to tell the team whether the cooling was proceeding correctly, whether the cardiac arrest had been achieved, whether the temperature was holding, whether the rewarming was proceeding safely. They were not designed to record anything about the inner life, if any inner life remained, of the woman lying motionless on the table. And yet, the question of what Pam Reynolds experienced during the standstill phase of her surgery at the Barrow Neurological Institute is not a question that can be dismissed by pointing to the flatness of the EEG trace. And the EEG measures cortical electrical activity across a limited area of the brain's surface. It does not measure everything that a brain does or is. It does not measure by its nature the absence of all neural process. It measures what it is positioned to measure in the frequency ranges it is calibrated to detect at the moment it is recording. A flat isoelectric EEG is a significant clinical finding. It is one of the criteria used to assess depth of anesthesia, and in certain contexts, the depth of the neurological suppression produced by hypothermic cooling. But what it establishes and what it leaves open are not the same thing. What Pam Reynolds reported after the surgery was completed and she was recovering was specific and detailed and grounded in the particular physical reality of the operating room she had been lying in. She described things about that room that she had not been conscious to observe by any conventional account of how consciousness works during a state of hypothermic cardiac arrest. She described the instruments, she described what was said, she described the procedure in terms that the surgical team who had been present in the room found, when they heard her account, consistent with what they remembered. But the question of what that consistency means, what it establishes, what it suggests, and what it leaves unresolved, is a question that does not have a clean answer at the bottom of it. The case has been investigated, it has been published, it has been argued over by people with serious credentials who have looked at the same evidence and arrived at genuinely different conclusions. None of those conclusions, including the most skeptical, fully account for everything the record contains, and none of them, including the most expansive, can be established beyond the kinds of challenges that careful analysis continues to raise. What is established at the beginning of all of this is the simplest and most human part of it. In 1991, in Atlanta, Georgia, A 35-year-old woman named Pam Reynolds received a diagnosis that changed the terms of her life without her permission. She was a musician. She was a professional, a person who worked at her craft with the daily seriousness that professional work requires. She had symptoms she had gone to investigate and found herself instead inside a conversation about a structure in her brain and what it would take to repair it. She had traveled to Phoenix, sat across from one of the most skilled surgeons in the world, and listened to him describe a procedure in which the only way to save her life was to arrange, by deliberate clinical design, for every machine in the room to read silence. Her heart would be stopped. Her blood would be drained from the space where the aneurysm lived, behind her eyes and above the structures that governed her breathing and her heartbeat. Her temperature would fall to a number far below anything the body sustains on its own. And in that state, in the particular stillness that only that procedure can create, Robert Spetzler would work. The plan was to stop Pam Reynolds completely, to bring her by every clinical measure to a condition indistinguishable from death. And then, when the work was done, and the aneurysm was clipped, and the surgical field was closed, and the machine was restarted, to bring her back. That was the proposal. That was what she had agreed to. That was what she was traveling to Phoenix to do. There is a particular quality to a fact that remains strange, no matter how many times it is stated plainly. Hypothermic cardiac arrest, described in clinical language, is a procedure with a documented physiological basis, a coherent rationale, and a record of use in cases where no other approach is available. All of that is true, and it is also true that the procedure requires, as a technical necessity, the complete cessation of the functions that define, in every practical and clinical context, what it means to be alive. The heart stopped, the blood stilled, the brain silent, the body cold. The only way to save the life was to, for a measured and carefully managed interval, end it. That is not a metaphor. It is the operative plan stated as a clinical fact, and it sits with the particular unhurried strangeness of something that is simply and genuinely remarkable. In the operating room at the Barrow Neurological Institute, on a November morning in 1991, the cardiopulmonary bypass machine was positioned to the left of the operating table and running, its tubing, clear, flexible, perhaps a centimeter in diameter, carried Pam Reynolds's blood in a circuit that looped outside her body through a membrane oxygenator no larger than a small appliance and back. The machine had its own quiet sounds, a low mechanical hum, the soft percussive pulse of the pump head turning, nothing loud, nothing that would have seemed, to a person standing at the door of the room, particularly remarkable. The procedure that was about to unfold had been performed before at Barrow, though never routinely. Robert Spetzler's team had refined it over years of work on aneurysms that occupied the same dangerous territory, deep basilar, sitting within the narrowest margins between accessible and unreachable. The operating room had been prepared the way it always was for this kind of case, which meant more equipment than usual, more people than usual, and a particular quality of attention in the room that the nursing staff described as concentrated rather than tense. Everyone present understood what the next several hours would require. The preparation for that understanding had happened long before the morning of the surgery itself. Pam Reynolds was 35 years old. Pure, she had been brought into the room, positioned on the operating table, anesthetized by the time the bypass machine's tubing was connected to the cannulas that had been placed in the vessels at her groin. The anesthesia team had already completed their work. Her airway was managed. Her vital signs were being monitored continuously on a bank of screens arranged along the wall to the left of the surgical field, each one displaying a different measure: heart rate, blood pressure, oxygen saturation, temperature. For the moment, all of them were reading within normal range. That would change deliberately and carefully over the next several hours. The cooling began slowly. That was essential. The bypass machine's heat exchanger, a component designed to bring the temperature of the circulating blood up or down in controlled increments, was set to begin reducing the temperature of the blood flowing through it. The blood leaving Pam's body through the bypass circuit was warm. The blood returning to it was fractionally cooler. Not dramatically, not all at once. The reduction was gradual enough that the body's cells, receiving slightly cooler blood with each pass of the circuit, had time to adjust to the change rather than registering it as an insult. The target temperature was approximately 60 degrees Fahrenheit. That figure, 60 degrees, is worth holding for a moment against what it means in ordinary terms, because the number alone does not quite carry the full weight of it. The human body's normal core temperature sits at 98.6 degrees. The cooling required for this procedure would bring Pam Reynolds' core temperature down by nearly 40 degrees over a period managed in minutes and hours, not in the sudden, uncontrolled way a person might experience exposure to cold. The difference is the difference between the body resisting an intrusion and the body being guided, step by careful step, into a state of profound biological stillness. At 60 degrees, cellular metabolism slows to a fraction of its normal rate. Oxygen demand drops. The brain, which under ordinary circumstances tolerates interruptions in blood flow for only a matter of minutes, becomes tolerant of interruptions that would otherwise be catastrophic. That tolerance was the reason for the cold. The cold was the whole logic of the procedure. The room held its temperature while Pam's dropped. The surgical lights were positioned above the table, but not yet directed at the operative field. That adjustment would come later. The monitoring screens continued their quiet display of numbers and waveforms, and the anesthesiologist recorded observations at regular intervals on the chart that sat on a small mounted surface to the right of their station. The perfusionist, the specialist whose role was to manage the bypass circuit, monitor the blood gases coming through the machine, and track the temperature readings at multiple points in the system, stood at the bypass machine and watched its readouts with the particular stillness of someone whose job requires constant attention and very little visible movement. There is a quality to the work done in an operating room during the slow phases of a complex procedure that is difficult to describe from the outside. Not every moment is active. Not every minute involves an instrument being moved or a decision being made. Much of the time, during a procedure like this one, is spent monitoring, watching numbers change, confirming that the change is within the expected range, and recording that it was. The action is distributed across time, and the action that matters most in the early phase of a hypothermic cardiac arrest procedure is the action of the machines and the body responding to them. The surgical team waited with the kind of patience that is itself a professional skill, the kind that knows the difference between a pause that requires intervention and a pause that requires nothing more than continued attention. Pam's body temperature moved downward through the 90s, through the 80s, passing through ranges that in any other context would indicate a medical emergency, while in this context indicated only that the cooling was proceeding as planned. At around the low 80s, the heart tends to become irritable, prone to arrhythmia, to the kind of irregular electrical activity that the bypass machine was designed to manage and absorb. The monitoring screens registered this. The team registered it too, watching for the specific patterns that would indicate a problem as distinct from the expected irregularity of a heart being asked to slow its own activity in response to a body growing cold around it. At some point in the low 80s Fahrenheit, the heart of Pam Reynolds stopped beating, not because of a crisis, because the cold had done what the cold was meant to do. The heart stopped, and the bypass machine continued. At that moment, the bypass machine was, in the most literal possible sense, the only thing maintaining circulation in Pam Reynolds's body. It was taking over a function the heart had just relinquished, doing what the heart does, oxygenating blood, driving it through the circuit with the same unhurried mechanical consistency it had demonstrated since it was switched on. The machine does not pause. It does not register the significance of what it has just assumed. It runs, and the blood moves, and the temperature continues its slow descent towards 60 degrees. When the target temperature was reached, the surgical team made an adjustment. The operating table tilted. The mechanism for this is built into the table itself, a hydraulic adjustment that changes the angle of the surface without disturbing the patient's position on it. What the tilt accomplished was a matter of basic physics. With the head end of the table lowered below the level of the torso, the blood remaining in the cranial cavity, the blood inside the skull, pooled in the vessels, and the surgical field above the brainstem would drain away under the influence of gravity. The bypass machine was turned off. The circuit stopped. No blood was circulating. No heart was beating. No blood was flowing into or out of the cranial vault. For the surgical team, this was the moment they had been working toward since the procedure began. The aneurysm, the swollen, pressurized bulge in the wall of the basilar artery that had made conventional surgical access impossible, was no longer pressurized, with no circulating blood to fill and stretch it. The aneurysm deflated. It went from a taut, dangerous, balloon-like protrusion that could rupture catastrophically if disturbed, to a soft, manageable collapsed structure that could be approached and addressed. The deflation took only moments. The change it represented, from the thing that had made this case inoperable by conventional means to something that could be worked on, was the entire reason for the hour of careful, managed cooling that had preceded it. The surgical field was pale, not white, not bloodless in the absolute sense that the word implies. There was residual fluid. There was the tissue of the brain itself. There was the carefully maintained exposure of the operative corridor that Spetzler's team had established through the opening in the skull, but pale in the way that a field drained of circulating blood is pale, quiet, still, the ordinary redness of vascularized tissue replaced by something closer to the color of tissue at rest, at depth, at cold. The team had perhaps an hour, perhaps a little more. The window of safety that the hypothermic arrest created was not unlimited. The cells of the brain, slowed by cold to a metabolism capable of tolerating the interruption, would not tolerate it indefinitely. The work had to proceed. Before the standstill phase began, before the cooling had even reached its target, the surgical team had made another preparation. 2 small devices, molded to fit snugly within the canal of each ear, had been fitted into Pam Reynolds's ears before the procedure started. They were speaker inserts, compact and precisely molded, designed to deliver a continuous series of auditory clicks directly to the eardrum. The clicks were loud, approximately 100 decibels, the level of sound produced by a very loud concert or a pneumatic drill at close range. They were not there to be heard in any ordinary sense. They were there because the brainstem, even under deep anesthesia, responds to auditory stimuli with measurable electrical signals. The brainstem auditory evoked potential is a tiny voltage, a fraction of a microvolt, generated in the neural tissue between the cochlea and the midbrain each time a sound is processed. Under ordinary anesthesia, this signal persists. Under hypothermic cardiac arrest, as the brain cools towards silence, it disappears. And the disappearance, the moment when the monitoring equipment stops detecting any response to the clicks still being delivered at 100 decibels into sealed ear canals, is one of the clearest available Striemst 1 confirmations that the brain has reached the state of neurological stillness the procedure requires. The clicks were playing throughout the early hours of the procedure. The monitoring equipment registered them and registered the brain's responses to them, small, regular, consistent. The technician watching the brainstem evoked potential readings would have seen the responses change as the temperature dropped, becoming smaller, slower, less regular as the neural tissue responsible for them cooled and slowed. The responses would have diminished gradually, following the temperature down until they too reached zero, until they flatlined, until the monitoring equipment was detecting the clicks being delivered, but detecting nothing coming back in response. The earplugs in Pam Reynolds' ears were sealed in place throughout all of this. The sound being delivered to her eardrums did not stop because her brainstem stopped responding to it. The clicks continued, regular, relentless, 100 decibels into ears that were producing no measurable reply. The monitoring equipment recorded this condition faithfully. It records what is there. It records what is not there. It does not interpret either. The craniotomy, the opening of the skull, had been completed before the standstill phase of the procedure began. It had to be, because the standstill window was too short and too precious to use for the surgical access work that could be accomplished while circulation was still maintained. The instrument used for that opening was the Midas Rex pneumatic cranial saw. It is a compact device, smaller than the name or the function might suggest. It runs on compressed air rather than electrical power. The compressed air line connects to the body of the tool and drives the mechanism that moves the blade. The blade attachments for the Midas Rex are interchangeable, each one designed for a specific cutting task, fitted into a case that keeps them organized and protected when not in use. The case, when open, presents its contents in individual molded recesses, each attachment seated in its own shaped space, the arrangement clean and functional. The Midas Rex runs at high speed. The sound it produces, a high-pitched, whirring tone, consistent and distinctive, different from the sound of an electrically powered drill, and different again from the sound of manual instruments, is audible throughout the operating room. Not loudly, not intrusively, but audibly. Surgical staff who have worked in rooms where the Midas Rex is in use describe the sound as something between a dental drill and a small pneumatic tool, specific, recognizable, the kind of sound that once heard in a particular context tends to remain associated with that context in memory. The skull was opened, the operative corridor was established. Spetzler and his team worked through the cranial access they had created, moving through the layers of tissue and membrane between the outer surface of the skull and the deep operative field where the aneurysm sat. This work, careful, incremental, requiring both the precision of individual instrument movements and the spatial awareness of three-dimensional navigation through neuroanatomy, was completed in the hours before the standstill was achieved. By the time the table tilted and the bypass machine was turned off and the blood drained from the cranial cavity, the surgical field was already open. The aneurysm was already visible. The only thing preventing access to it had been the pressure of the blood filling it, and that was gone. The cardiac surgical team had been present throughout the procedure to manage the bypass circuit and coordinate the cardiac aspects of the standstill. Their involvement had begun at the groin, where the cannulas for the bypass circuit had been placed. The femoral artery, the large vessel running through the thigh, is the standard access point for bypass cannula placement in procedures of this kind. The vessel is located by feel and by anatomical landmark, exposed surgically and cannulated in a process that is routine in cardiac surgery, but that, like any surgical procedure, occasionally presents anatomical variations. Vessel size varies. The particular dimensions of the femoral artery in a given patient can require the surgical team to make adjustments to their approach, different cannula sizes, different placement strategies, decisions made at the table based on what is found there. These are the ordinary contingencies of surgery. They happen, the team addresses them, the procedure continues. The cardiac surgical component of the team had been doing exactly this kind of work in the hours before the standstill was achieved, while the neurosurgical component prepared the cranial access and the perfusionist managed the bypass circuit and the anesthesiologist monitored the whole system. 8 people or more were in the room at the moments of peak activity. Their communication was low, efficient, specific, the kind of speech used by people who know the vocabulary of the work they are doing and do not need to translate it into ordinary language for each other. They said what the task required. They moved on. The operating room at Barrow Neurological Institute on that morning was a room full of equipment, organized for a specific purpose, staffed by people with specific skills, directed toward a specific goal. The lighting above the surgical field was bright. The rest of the room was dimmer. The monitoring screens along the wall were active. The bypass machine stood in its position to the left of the table, its tubing connected, its pump running or stopped depending on the phase of the procedure. The instrument trays held their contents in the arrangement established by the scrub technician before the first incision, tools that had been counted, confirmed, and positioned for the sequence of tasks ahead. There is something worth attending to in the physical arrangement of a room organized this completely around a single body. The whole space, its equipment, its personnel, its particular management of light and sound and temperature exists in relation to the person on the table. The monitors measure that person's condition. The machines maintain or alter that person's condition. The instruments are directed at that person's anatomy. The training of everyone in the room has prepared them for precisely this kind of case, and yet the arrangement is oddly impersonal in its appearance, efficient, designed for function rather than for acknowledgement of the particular person who is at its center. Pam Reynolds, 35 years old, a working musician from Atlanta, a person with a name and a family and a voice that had recorded albums and performed in front of audiences, was in the formal register of what was happening in that room, a patient, a body to be managed through a precisely calibrated sequence of physiological states toward a surgical outcome that no other sequence of states could make possible. The flat paleness of the surgical field, the blue draping, the careful arrangement of the people around the table, none of this is impersonal in the way that indifference is impersonal. The precision is itself a form of care. The calibration of the cooling, the management of the bypass circuit, the confirmation of neurological silence through the brainstem monitoring, the prepared exposure of the operative field, the positioning of the instruments. Every element of the arrangement is there because of a specific judgment that it was the best way to give this particular person the best available chance. That is what all the equipment is for. That is what the people are doing. The cardiopulmonary bypass machine to the left of the table was now silent. Its pump had stopped turning. The tubing that still ran from the machine to the cannulas at Pam's groin carried no moving blood. The circuit was intact, but still, the heat exchanger, which had done its work over the previous hours, was no longer being called upon to do anything. It simply held the temperature it had reached and waited. The machine's monitoring readouts, blood gas levels, temperature sensors at multiple points in the circuit, showed the condition of a system at rest at a very low temperature, numbers rather than activity. A record of where things stood. The heart, still in Pam's chest, was not beating. There was no electrical activity propagating through the cardiac muscle, no sequence of contraction and relaxation, no movement of blood in or out of the chambers. The heart was a muscle in a cold body, and it was still. It would be brought back. That was the plan, the expectation, the whole orientation of every person in the room. But at that moment, it was still. The EEG electrodes attached to Pam's scalp were recording the electrical condition of the cortex. In the hours leading up to the standstill, the recording would have shown progressive slowing, the characteristic suppression of cortical activity that accompanies deep anesthesia, and then the further suppression that accompanies cooling. The waveforms would have grown smaller, slower, more irregular, then less distinct, then at some point in the descent towards 60 degrees absent. The electrodes would have continued recording, faithfully, whatever was present. And what was present, by the time the bypass machine was turned off, and the table tilted, and the blood drained from the cranial cavity, was a flat line, a single horizontal trace, unbroken, unvaried, extending across the screen of the EEG monitor with the steady, undemonstrative quality of a measurement that is recording the complete absence of the thing it is designed to detect. The brainstem monitoring had shown the same progression and arrived at the same conclusion. The clicks in the sealed ear canals, still playing, still delivering their 100-decibel signal, had stopped producing a response. The small auditory evoked potential that the brainstem had been generating right up until the cooling reached its threshold had disappeared. Both measures of neural activity, the cortical and the brainstem, were simultaneously flat. The monitoring equipment was measuring silence in both registers. The room around it was quiet, except for the soft ambient sounds of the ventilation system and the low background noise of equipment on standby. Robert Spetzler stood at the operating table. The surgical field below him was pale and still. The aneurysm, the structure that had brought Pam Reynolds from Atlanta to Phoenix, that had required all of this preparation and equipment and organized clinical skill, was deflated and accessible. For the first time since it had been identified on imaging, the swollen arterial wall that had been pressing against the base of the brainstem from within was soft, manageable, something that could be worked on. Spetzler's instruments were positioned for the work. His team was in place. The monitors along the wall read what they read. No heartbeat, no blood flow, a flat cortical recording, a flat brainstem recording, a core temperature of 60 degrees Fahrenheit. A body in a state that the clinical vocabulary of the room described, with complete accuracy and without particular emphasis, as standstill. The word itself is plain enough. A thing that was moving has stopped. A process that was running has paused. It carries no drama in its syllables, no rise, no fall, just the flat, even quality of a situation held in suspension. Stand still. And yet in the room at the Barrow Neurological Institute, on that morning, the thing that was standing still was the sum of the biological processes that under any ordinary circumstance define the condition of being alive. The heart was not beating, the blood was not moving. The brain, by both of the measures the equipment was capable of providing, was producing nothing. The instruments Spetzler held were poised above a collapsed aneurysm in a surgical field that had been made accessible only by bringing every machine designed to measure life in that room to a simultaneous reading of silence. That silence was the goal. It was the condition the procedure required. It had taken hours of careful, deliberate, precisely managed work to achieve it, and the people in the room had done that work with the steady expertise their training had built. The standstill was not an accident. It was not a failure. It was the outcome that allowed the surgery to proceed. And in the pale, still, carefully lit space of the operative field, Robert Spetzler began. The compressed air line to the Midas Rex had done its work earlier in the procedure, its high-pitched tone filling the room and then going quiet again when the cranial opening was complete. The blade attachments were back in their case on the instrument tray, each one fitted into its molded recess, the compact silver handle of the tool resting in its own shaped space beside them. The case sat closed now, its contents organized and still, having contributed their part to the procedure and waiting quietly in the ordered arrangement of the instrument tray for whatever else the morning might require. The monitoring screens continued their display, numbers and flat lines, temperature readings holding steady at their cold target, blood gas values reflecting the stillness of a circuit no longer running, the EEG trace extending its long, unbroken horizontal across the screen, unvaried, unhurried, simply there. Every machine in the room, designed to detect the activity of a living body, was reading the same thing in its own register, and Robert Spetzler, in the pale and motionless field the cold had made possible, worked on in the particular silence of a room where every measure of life had gone quiet and the work itself continued. The last of the brainstem signals disappeared from the monitoring screen at a precise and documented moment during Pam Reynolds' surgery at the Barrow Neurological Institute. The equipment had been measuring her brainstem's faint electrical responses to auditory clicks throughout the procedure, 100 decibels of sound delivered continuously through the molded inserts sealed in her ear canals, and for a time those responses had been present. Small and regular, a record of a brainstem still receiving and processing sensation. Then they were not. The EEG had already gone flat. The cortical silence had already been established and recorded. What disappeared last was the deeper signal, the brainstem's own quiet answer to the clicks, and when it went, the monitoring equipment on both channels was reading the same thing at the same time. Nothing, no wave, no flicker, no measurable activity at any level of the brain that the instruments could reach. The room continued its work around that silence. The surgical team was present. The monitors were running. The temperature logs were being maintained. And by every clinical measure available to the people in that room, the woman on the table was not producing anything that the instruments recognized as the activity of a living brain. What Pam Reynolds later reported experiencing during that window has been described by her and recorded by investigators in specific and consistent terms across many years of telling. The account did not shift in its essential details. The core of it remained the same, whether she was speaking to a cardiologist reviewing her medical records or to a documentary filmmaker arranging a camera across a quiet room. She described the sensation of rising, not floating in the way the word is sometimes used loosely, but rising with what she characterized as a clear sense of direction, upward, away from the table, away from her own body, and arriving at a vantage point from which she could observe the surgical scene below her. She described this perspective as stable. She was not spinning, She was not moving through anything. She was simply located, clearly and calmly, at a point above the operating table, and from that point she could see. What she described seeing was specific. It was not a blurred impression of a room. It was not the generalized sense of an operating theater that anyone who had ever seen a hospital program on television might reconstruct. The details she reported were particular and technical, and in several documented instances, accurate to the actual conditions of that room at that moment in a way that has been carefully noted by the investigators, who later compared her account against the operative record. She described the top of her own head, partially shaved for the surgical approach, visible from above. She described the positioning of people around the table. She described the sounds of the room, not the ambient sounds of machinery and ventilation, which would require no particular observation, but specific sounds attached to specific objects being used at specific moments. And she described the bone saw. The pneumatic cranial saw used to open Pam Reynolds' skull was the Midas Rex system, a device powered by compressed air, compact in design, with a handle that she described as resembling an electric toothbrush. It was not a large tool. It was not shaped like the power tools most people would associate with the word saw. Its handle was smaller, more clinical, more precise, and the interchangeable blade attachments that fit to the end of it were stored in a fitted case that she described as resembling a socket wrench set, with each attachment seated in its own molded compartment in the interior of the case. She described the tool as it was before it was used. She described the case as it appeared when it was opened and set out on the instrument tray. The sound it produced she described in terms that matched the pneumatic whirring of compressed air through the mechanism, a sound markedly different from an electrically powered drill, lighter and higher in its register. The description she gave was not the description of someone who had been told about the tool afterward and was reconstructing it in general terms. It was the description of someone who appeared to have seen it. The surgical staff who were present in the operating room and who were later interviewed as part of the post-operative investigation confirmed that her description of the Midas Rex saw was accurate. Not approximately accurate. Accurate in the specific details that she reported: the shape of the handle, the arrangement of the blade attachments in their fitted case, the character of the sound the device produced when it was in use. These were not details that appeared in any publicly available description of the procedure. They were not details that could have been inferred from general knowledge of surgical practice. The Midas Rex was a specialist tool used in neurosurgery, and its appearance, compact, toothbrush-handled, stored in a fitted case like a socket wrench set, was not the kind of detail a patient would encounter in any preparatory conversation with a surgical team. There was a second observation in Pam's reported account that investigators paid careful attention to. She described, from her overhead vantage point, overhearing a conversation involving a female member of the surgical team. The conversation, as Pam reported it, concerned the blood vessels at the access point in her groin, the femoral site where the cardiopulmonary bypass cannulas were being placed. What the female surgeon said, as Pam reported it, was that the vessels there were too small, that the access was not straightforward, that there was a problem at the femoral site that required attention. Post-operative investigation confirmed that a complication involving the femoral artery access had in fact occurred during the procedure. The vessels had been smaller than expected. A female cardiac surgeon had been involved in addressing the problem at that site. The conversation, or something consistent with the conversation Pam described, had happened at the femoral site involving a female surgeon concerning the size of the vessels. What Pam reported overhearing was consistent in its documented essentials with an actual event that took place in that room. The weight of these two observations, the Midas Rex saw and the femoral artery conversation, lies in what they imply about the conditions under which they were made. Both observations involved specific technical content that Pam could not plausibly have known in advance. The bone saw's appearance and storage arrangement were not discussed with patients. The femoral artery complication was not something that could have been anticipated or described generically. If Pam had been conscious and alert at the moment these things occurred, her account would be straightforward: a patient who woke during surgery, briefly, and perceived things around her before losing awareness again. Anesthetic awareness, the documented phenomenon in which a patient under general anesthesia retains some degree of conscious experience without being able to move or signal, would explain the situation simply and without invoking anything outside conventional neuroscience. But Pam's neurological state at the time of the procedure is documented on the monitoring record. The EEG was flat. The brainstem auditory evoked potentials were absent. The cooling had proceeded to the target temperature of approximately 60 degrees Fahrenheit. By the standard clinical measures used by the team managing her care and recorded on the instruments running throughout the procedure, Pam Reynolds had no measurable brain activity at the moment she was later found to have been, in some sense, perceiving. This is the specific condition of the case that has made it a subject of sustained and serious attention over the years since the surgery. It is not simply that Pam Reynolds had an unusual experience during a medical procedure. Many people report unusual experiences under anesthesia. It is not simply that she perceived things accurately. Anesthetic awareness can produce accurate perception. What makes the Reynolds case sit differently from those comparisons is the documented simultaneity, the flat EEG, and the accurate perception occurring at the same time, during the same window, with both the neurological record and the observational content preserved and cross-referenced. The monitoring record was not reconstructed after the fact. It was running continuously throughout the procedure. The temperature logs are real. The EEG readout is real. The brainstem monitoring data is real. And the account Pam gave of what she observed during that window is specific enough and accurate enough in its verified details that the question of how to hold both things at once, the silence of the monitors and the content of her perception, has not resolved itself into any single satisfying answer. The feeling that Pam described from her overhead vantage point was not distress. That is worth noting, because the clinical picture of a body in standstill, heart stopped, blood drained, temperature dropped to 60 degrees, brain electrically silent, carries a particular gravity when described from the outside. From the inside, by Pam's account, the experience was characterized by clarity. She described feeling calm. She described seeing clearly. She described the quality of the perspective as different from ordinary vision, sharper in some ways, wider in others, but not disorienting. She was not frightened of what she saw. She was not confused about what was happening below her. She recognized the operating room. She recognized the procedure being performed on her body. She understood that the body on the table was hers, and she was not in it. The understanding, as she described it, was simply present, not arrived at through reasoning, not disturbing in the way that the intellectual content of that understanding might suggest it should be, but simply there, clear and quiet, and held without alarm. The flat line on the EEG monitor had been reached through a gradual process. As the bypass machine cooled Pam's circulating blood, her brain activity had not switched off at once. It had slowed. The characteristic wave patterns of an active cortex had become less frequent, less organized, lower in amplitude. until they had lost their shape entirely and the trace had gone flat. This is the documented progression of cortical function under deep hypothermia, and it proceeded in Pam's case along the expected curve. The brainstem signals had persisted longer, the brainstem being more resistant to hypothermic suppression than the cortex, and they had been present, the monitoring equipment recording them faithfully up to the point at which they too disappeared. There was no ambiguity in the readout. The instruments were working, the electrodes were correctly placed, the auditory clicks through the earplugs were being delivered at the documented level. What the equipment was recording at the point when both measures went flat was the genuine absence of measurable neural activity rather than an artifact of equipment failure or signal interference. The people managing the monitoring were professionals operating in a major neurosurgical facility, and the records they produced have been reviewed by multiple independent investigators over multiple decades without anyone finding grounds to question their basic integrity. The standstill itself lasted for a period that has been documented at approximately 45 minutes to 1 hour within the broader surgical procedure. During that window, Pam's core body temperature held at approximately 60 degrees Fahrenheit. Her heart was not beating. Her blood was not circulating. The bypass machine had been switched off. The cranial cavity was pale and still, its vessels emptied by gravity. The aneurysm collapsed and accessible in a way it could not have been under normal circulatory pressure. The surgical team was working in that stillness, carefully, precisely, in the particular focused quiet of a procedure that could not be paused or repeated. And Pam Reynolds was, by the recording of the instruments that surrounded her, producing no measurable activity in the brain that would normally be considered the seat of experience, memory, and perception. What she later described perceiving during that window is the part of the case that does not fit neatly into the documentation around it. Not because her account is implausible as a human experience. People report altered states of perception under many conditions, and the brain, under extreme physiological stress, is capable of producing experiences of great complexity and apparent clarity. The difficulty is more specific than that. It is the accuracy. The description of the Midas Rex saw in terms that surgical staff confirmed as precise. The description of the femoral artery conversation in terms that post-operative investigation found consistent with an actual event. The stability of the account across multiple tellings over many years. The particular quality of the details, not general impressions of an operating room, but specific observations of specific objects and specific conversations at specific moments. If the brain that produced those accurate observations was, at the moment of observation, not producing any measurable electrical activity at all, then the case poses a question that the monitoring record and the observational record together do not answer. The earplugs sealed in Pam's ear canals continued to deliver their 100 decibel clicks throughout the standstill. The auditory pathway from the ear canals to the brainstem is among the more robust in the nervous system. It does not require higher cortical involvement to produce a measurable response, only the intact function of the brainstem itself. When that function is present, the monitoring equipment records it. When it is absent, the equipment records absence. During the standstill, the equipment was recording absence. The clicks were being delivered. The brainstem was not answering. This was expected. The whole design of the monitoring system was to confirm precisely this condition, the complete suppression of brainstem function, because the surgical procedure required it. What was not designed into the monitoring system, and what no one in the room was tracking or anticipating, was the possibility that something in the clinical picture might not be captured by the instruments running beside the table. The description Pam gave of the Midas Rex case, its fitted compartments, its molded interior, each blade attachment seated in its own recess, has been returned to many times by the investigators and researchers who have studied the case, because it is one of the most specific and verifiable elements in her account. A person describing a dream about surgery might describe a large saw, a noisy tool, a bladed object of some generic kind. A person describing a hallucination reconstructed from prior knowledge of medical procedures might describe something more specific, but still within the range of what general knowledge would suggest. The description Pam gave does not fit either of those categories, but describes a specific device in specific terms, including the storage arrangement of its components, in a way that corresponds to the actual object present in that room. The correspondence was noted by the surgical staff who were asked about it afterward. They confirmed that she had described the Midas Rex accurately. The femoral artery conversation occupies a slightly different evidentiary position. The description of what the female surgeon said, that the vessels were too small, corresponds to a real complication that post-operative investigation found had occurred. But conversations are harder to verify than objects. A person reviewing the operative record could confirm that a femoral access complication occurred. They could confirm that a female surgeon was involved at that site. What they cannot confirm with the same precision is the exact wording of what was said, because no contemporaneous transcript of the conversation exists. What the investigation established was that the conversation was consistent with what Pam described, that a problem involving vessel size did occur at the femoral access site, that a female surgeon was present and speaking about it, and that Pam's account of having overhead something on that subject corresponds, in its general content, to something that actually happened. The precision of the Midas Rex description and the confirmed consistency of the femoral conversation together form the evidentiary core that has kept the Reynolds case in active discussion for decades. There is a quality to Pam's account that tends to be noted by people who have read it in full, a quality of coherence, not the coherence of a carefully constructed narrative assembled after the fact, but the coherence of a person describing something they genuinely remember. She did not embellish. She did not escalate. She did not describe the experience in terms designed to maximize its impressiveness or its strangeness. She described it in the specific, slightly ordinary language of someone recounting a memory. The saw looked like an electric toothbrush. The case looked like a socket wrench set. The female surgeon said the vessels were too small. These are the details a person might use to describe something they saw, not something they imagined or constructed. The flatness of the description, its refusal to perform its own significance, has been remarked on by more than one researcher who has spent time with her account. The clinical window of approximately 45 minutes to 1 hour, during which Pam had no measurable brain activity, is a documented fact. The account she gave of what she perceived during that window is a documented fact. The confirmation by surgical staff that specific elements of her description were accurate is a documented fact. What connects these three documented facts, or whether they are connected in the way that Pam's account implies, is not a documented fact. Where does the open question that the case leaves behind, sitting quietly at the center of the monitoring record and the operative timeline and the specific, consistent, verifiable description of a compact silver tool with interchangeable blade attachments stored in a case that looked, she said, like a socket wrench set? The EEG readout from Pam Reynolds' surgery shows a long flat line. The line begins when the cooling is proceeded far enough to suppress cortical activity and ends when the procedure is complete and rewarming is underway. Along that line, there is no variation, no spike, no flicker, no period during which the cortex offers anything the instrument can record. The line is simply flat. It runs across the page, or in the original, across the monitor's screen, without interruption, without artifact, without any feature that would suggest the presence of the kind of neural activity that neuroscience associates with perception, memory formation, or conscious experience. And somewhere along that line, in the portion of it that corresponds to the standstill phase, the woman whose brain produced it was, by her own consistent and partly verified account, looking at the Midas Rex, saw in its fitted case on the instrument tray, and listening to a female cardiac surgeon describe a problem with the size of the vessels at the femoral site. These two things, the flat line and the account, are both real. They sit beside each other in the case record. They have been read by cardiologists and neurologists and neurosurgeons and consciousness researchers and philosophers of mind, and none of them have produced an explanation that has satisfied everyone who has reviewed the case with care. Some have proposed that the observations were made before standstill was complete, during the cooling phase, when Pam was deeply anesthetized, but the brain was still producing some level of suppressed activity. Others have found the accuracy of the verified details difficult to accommodate within that timeline, noting that the bone saw would have been in use after standstill was achieved, not before it. The debate has continued. The case record has remained available. The flat line has remained what it is. What Pam Reynolds remembered from inside a procedure designed to produce the deepest possible suppression of brain function is preserved in a collection of documented accounts, interviews with researchers, testimony in published investigations, appearances in documentary film, consistent retellings across 19 years until her death in 2010. In every telling, the essential details held: the handle of the saw, shaped like an electric toothbrush, the blade case, fitted and organized like a socket wrench set, the female surgeon's voice, saying the vessels were too small. These were the specific things she carried back from a room where, by every instrument running beside her, nothing was happening. The monitoring record shows silence. Her account shows detail. The case file holds both and leaves them there, side by side, on pages that have been turned over many times without the gap between them closing. The Midas Rex saw was returned to its case after the surgery. The cranial opening was closed. Pam's temperature was slowly raised. Her heart was restarted. The EEG trace resumed its normal activity as her cortex came back online. The flat line broken by the first returning flicker of a brain warming up from 60 degrees and beginning once more to show the instruments what it was doing. She survived the surgery. The aneurysm was successfully clipped. She went home to Atlanta. And in the days and weeks following the procedure, she began describing what she had experienced in the operating room, describing the saw, describing the conversation, describing the vantage point above the table, before any formal investigation had been organized, before anyone had thought to compare her account against the operative record, before the case had become a case. The instrument tray, at the moment of standstill, held the Midas Rex in its fitted case, with the blade attachments nested in their compartments. The EEG monitor held its flat green line. The brainstem monitoring equipment recorded only the clicks it was sending and nothing coming back. The operating table held a woman whose heart had been stopped and whose body had been cooled to 60 degrees and whose brain was producing, as far as the instruments could tell, nothing at all. The room was quiet except for the ventilation and the soft mechanical sounds of equipment running its measurements. The surgical team worked in the particular stillness of standstill, and the case she described later, Compact, silver, its interior fitted to hold each blade in its own place, looking, she said, like a socket wrench set, was sitting on the instrument tray exactly as she described it, in a room where no one expected anyone to be watching. In the days following her surgery at the Barrow Neurological Institute, before anyone had formally debriefed her, before any investigator had arrived with a notepad and a list of questions, Pam Reynolds began telling her surgical team what she had observed. She described the bone saw. She described a conversation about her blood vessels. She described the angle of the room from a position that was not the position of the table. The account came before the investigation, and that sequence, the account first, the examination of it afterward, is where the case has continued to sit, quietly and without resolution, for more than 3 decades. Michael Sabom was a cardiologist working in Atlanta who had spent years gathering accounts from cardiac arrest survivors. He had heard many reports of perception during clinical unconsciousness, and he had developed a methodical approach to examining them, interviewing witnesses, pulling medical records, mapping the timeline of reported observations against the documented sequence of procedures. When he encountered the Reynolds case in the mid-1990s, he began the same process he had applied to others, and the work eventually produced a chapter in his 1998 book, Light and Death. What made the Reynolds case different from others he had examined was the documented neurological baseline against which her account was set, not simply the absence of heartbeat or blood flow, which could be found in many cardiac cases, but the flat EEG and the absent brainstem responses recorded simultaneously during the period she later described as one of clear perception. Sabom interviewed Pam Reynolds at length. He reviewed her operative records. He spoke with members of the surgical team who had been present in the room. When he cross-referenced her account against the documented timeline of the procedure, he published his conclusion that certain elements of her description were consistent with events that had actually occurred, and that her account represented one of the most evidentially robust instances of reported veridical perception in the existing near-death literature. That word, veridical, means simply that the perception can be externally verified. Sabom was not claiming the perception was supernatural. He was claiming that specific things Pam Reynolds said she had observed corresponded to specific things that the operative record confirmed had occurred. Robert Spetzler had performed tens of thousands of surgical procedures across a career that had made him one of the most respected cerebrovascular surgeons in the world. He was not a man given to imprecision in language or to easy acceptance of claims that exceeded the available evidence. When asked about Pam Reynolds' account in interviews and public appearances over the years that followed the surgery, he was measured and consistent in what he said. He did not say that he believed she had been conscious. He did not say that her experience proved anything about the persistence of awareness beyond neurological silence. What he said was that certain elements of her account were difficult to place within any conventional explanation he was aware of, and that the case was one he took seriously, not in spite of his scientific training, but because of it. The word he used in at least one recorded interview was unexplained. He used it carefully. He did not use it as a synonym for impossible or miraculous. He used it in the way a surgeon uses a word like that, to mean that the available frameworks do not currently account for the observation, and that the observation has not gone away. That quality of careful language, held by a named credentialed professional who had been present in the room, is part of what gives the Reynolds case its particular weight in the literature. Spetzler's acknowledgement of what he did not understand was not a concession to belief. It was a statement about the limits of what he could explain, and the distinction matters because the case sits inside that gap between what was documented and what any currently available model accounts for, and has continued to sit there, calmly and without resolution, across the years since the surgery was performed. Gerald Warley was a Dutch anesthesiologist who had spent a considerable portion of his professional life examining accounts of near-death perception from the standpoint of anesthetic pharmacology and neurophysiology. He read the Reynolds case with the same methodical attention Sebum had applied, and he arrived at conclusions that differed substantially from Sebum's. His argument was not that Pam Reynolds had fabricated anything, and it was not that her account was without detail. His argument was about timing. The documented procedure at Barrow Neurological Institute did not move from fully awake to neurologically flat in a single moment. There was a period of deep anesthesia before standstill was achieved, a window during which Pam Reynolds was unconscious, unresponsive to external stimulation, and registering a slowed EEG, but during which residual perceptual processing could not be entirely excluded. Worley proposed that the observations she later described, particularly those involving the bone saw and the positioning of the team, were most plausibly located in that earlier window rather than in the standstill phase itself. The phenomenon he was invoking was anesthetic awareness, a documented and scientifically accepted phenomenon in which patients under general anesthesia retain a degree of perceptual access to their environment without being able to respond or communicate. It has been recorded in surgical cases across multiple institutions, and in some instances involves remarkably detailed subsequent recall. Welity published his analysis in the peer-reviewed literature and engaged with the Reynolds case, not as a curiosity, but as a specific clinical puzzle, amenable to a specific clinical explanation. His work was careful. His conclusion was that the extraordinary elements of the case did not require an extraordinary mechanism to account for them, that the tools already available to neuroscience and anesthesiology were sufficient, if applied correctly to the timeline, to place Pam Reynolds's observations within the period before the monitors went flat. The response to Welity's analysis from within the near-death research community was substantive. Investigators who had studied the Reynolds case in detail pointed to specific elements of the account that they argued were difficult to locate within the pre-standstill window he had proposed. Among these was the reported conversation about the femoral artery, the exchange about blood vessel size that a female member of the cardiac surgical team had been involved in, which multiple accounts suggested had occurred during or after the bypass setup, a phase of the procedure that was itself occurring after the cooling process was underway. If that exchange happened when the operative timeline suggested it had, then placing Pam Reynolds's perception of it within an earlier phase of consciousness became more difficult to sustain. The investigators did not claim this resolved the question. They noted that it complicated the simple answer. Peter Fenwick was a British neurologist who held a position at the Institute of Psychiatry in London and had spent decades examining near-death experience accounts with a particular interest in what they could and could not establish about the neurological basis of consciousness. He had reviewed hundreds of accounts across multiple institutions and countries, and he brought to the Reynolds case the same measured, empirical attention he had applied to all of them. What he found most significant about the Reynolds case was not any single element of Pam's account, but the combination of factors that made the standard explanations difficult to apply cleanly. A flat EEG in isolation would be one thing. Absent brainstem evoked potentials in isolation would be another. Detailed, verifiable, specific observations during that window observations that were reported before any verification was sought and that were subsequently confirmed as consistent with the operative record, produced a combination that Fenwick argued the existing neuroscientific framework did not handle well. He was precise in what he was not claiming. He was not claiming the case constituted proof of any metaphysical proposition. He was not claiming that Pam Reynolds's experience established the independent existence of consciousness outside the brain. He was claiming that the case was genuinely difficult to explain within the models currently available to neuroscience, and that the difficulty was not a product of credulous investigation, but of careful examination of documented facts. Fenwick's position represented something close to the consensus of the serious near-death research community on the Reynolds case. Not that the case proved anything, but that it sat at a location where proof was not available in either direction, and that this location was itself significant. The challenge of verification in any case of this kind is not simply a matter of willingness or competence. It is structural. The events being investigated occurred during a surgical procedure attended by a team of 8 or more people who were fully occupied with the technical demands of an extraordinarily complex operation. No one in that room was assigned to keep a contemporaneous log of exactly which words were spoken at which moment. The operative record documented temperatures, blood pressures, gas concentrations, and the timing of major procedural steps. What it did not document was the precise sequence of incidental conversations, or the moment when the cardiac surgeon made the observation about vessel size, or which sounds from which instruments were audible at which phase of the procedure. The investigators who came afterward, Sabom, Fenwick, and others, were working from surgical team recollections gathered months and in some cases years after the procedure. Memory, even in careful and honest witnesses, is reconstructive. The team members who confirmed elements of Pam's account were not confirming them against a precise contemporaneous record. They were confirming them against their own recollection of a procedure that had taken place under conditions of considerable professional intensity. Critics who raised this point were raising it honestly, and the near-death research community largely acknowledged its force. The possibility that elements of Pam Reynolds' account were incorporated post-operatively, assembled from overheard conversations, from something said in the recovery room, from fragments of medical discussion she had been present for, could not be entirely excluded. This acknowledgement was not a concession that her account was fabricated. It was a recognition that the evidentiary standards available to this kind of investigation have inherent limits that no amount of care can fully overcome. What the case left behind was not a resolution, but a structure. On one side of the structure sat a documented neurological record, a flat EEG, absent brainstem responses, a body at 60 degrees Fahrenheit, with no heartbeat and no blood flow, maintained in that state for somewhere between 45 minutes and an hour. On the other side sat a detailed, specific, internally consistent account from a person who had been in that condition, describing observations that several members of the surgical team confirmed were consistent with what had actually occurred. In the middle sat the question that no investigator from any position on the spectrum of interpretation had been able to answer with the precision the question required. When exactly, within the overall timeline of the procedure, did those observations occur? If the timing could be established with certainty, if it could be demonstrated conclusively that the femoral artery conversation and the view of the bone saw were perceived during the standstill phase rather than before it, the case would look very different than if the observations could be placed in the earlier period of deep anesthesia. That timing has not been established with the certainty the question requires, and that gap in the record is where the case continues to rest. Sabom's book was not the last word on the Reynolds case, and he did not present it as such. Light and Death was a work of careful cross-referencing, the kind of document produced by someone who had decided to follow the evidence wherever it led and to report honestly on what he found at the end of the process. What he found was a case that resisted dismissal and resisted full verification in equal measure, and he said so. The book was reviewed, cited, and responded to by researchers across the spectrum of near-death studies, and the discussion it contributed to has continued in the peer-reviewed literature in the years since its publication. The Reynolds case appears in it regularly, not as a settled example, but as a persistent one, invoked whenever the question of veridical perception during neurological silence is being examined seriously. Its persistence in the literature is itself a kind of data point. If the case had been cleanly explained, it would have stopped being cited. It has not stopped being cited. The femoral artery complication remains one of the more specifically documented elements of Pam Reynolds' account, and it is worth dwelling on what the documentation actually establishes. Pam reported hearing a female voice remark on the size of her blood vessels during what she experienced as the bypass setup phase. Post-operative investigation confirmed that there had been a complication involving femoral artery access, that a female cardiac surgeon had been involved in addressing it, and that an exchange about vessel size had occurred during that phase of the procedure. The confirmation was based on the recollections of surgical team members, not on a contemporaneous written record. But the match between what Pam reported and what the team members recalled was specific enough that investigators from multiple positions found it difficult to attribute entirely to coincidence or to post-operative incorporation. Worley's response was to note that the timing of this element, while harder to place in the pre-standstill window than some others, still did not require anything beyond anesthetic awareness during the earlier phase of the procedure. The response to that response was to note that the bypass setup itself was taking place during the cooling phase, which would complicate the picture of what level of neurological function would have been present at that moment. The exchange between these positions has continued in published form across several years and has not yet produced a consensus. What it has produced is a more precisely detailed understanding of where the evidentiary uncertainty lies, and that kind of precision, in a field where loose claims are common, is its own contribution to the record. It is worth noting what Robert Spetzler did not say. Across the years of interviews and public discussion that followed the surgery, he did not claim that Pam Reynolds had been conscious during standstill in any neurological sense he could account for. He did not claim that the case proved anything about the survival of consciousness beyond the cessation of brain activity. He did not align himself with any interpretive framework that went beyond the documented facts. What he said, consistently and precisely, was that certain elements of her account did not fit the explanations he was aware of, and that this was something he found genuinely worth taking seriously. That posture, the willingness of a world-class neurosurgeon to sit with an unresolved question rather than dismiss it or explain it away, is itself part of the evidentiary record of the case. It does not establish what happened in that operating room. It establishes that a person who was present, who understood the neurological conditions better than almost anyone, did not find the conventional explanation satisfying. That is a narrower claim than it sometimes appears in popular accounts of the case, but it is also not nothing. The critics of the Reynolds case have made their arguments in good faith, and those arguments deserve to be held with the same careful attention as the arguments on the other side. Anesthetic awareness is a real phenomenon. Its incidence in surgical patients has been documented across large populations. The neurological conditions under which it can occur are not fully understood, and cases of unexpectedly detailed recall from periods of supposed unconsciousness appear in the anesthesiology literature independently of any near-death research. If Pam Reynolds was aware during the pre-standstill phase of her procedure, she would not be the first patient to have retained perceptual access during general anesthesia, and her subsequent account of specific observations from that period would not require any mechanism beyond the documented capabilities of a brain in a pharmacologically suppressed but not entirely non-functional state. The critics are not arguing against her credibility. They are arguing about neuroscience and timing, and those are arguments that deserve engagement on their own terms. The near-death research community has engaged with them, and the engagement has been productive in the specific sense that it has refined the questions without yet resolving them. One of the elements of the case that has received less attention than the bone saw or the femoral artery conversation is the stability of Pam Reynolds' account across multiple tellings over nearly 2 decades. She described her experience in interviews, in Sabum's investigation, in the BBC documentary The Day I Died broadcast in 2002, and in a range of other public and private contexts between 1991 and her death in May 2010. Across those tellings, the core elements of her account remained consistent. The shape of the saw, the case for the blades, the conversation she overheard, the angle from which she experienced the scene, these details did not drift or elaborate significantly over time. Critics of NDE accounts frequently note that memories can crystallize through repetition and become more detailed or more certain with each retelling, even without deliberate embellishment. That is a legitimate concern, but the stability of the Reynolds account across nearly 20 years of telling, without significant addition or contradiction, is also a feature of the evidentiary record that investigators have noted as meaningful. Memory that is fabricated or confabulated tends to drift. Memory that is stable across 2 decades, in the absence of contradicting evidence, has a different character, not conclusive, but different. The operative record from Pam Reynolds' surgery at Barrow Neurological Institute has been read by multiple investigators across multiple decades. Its temperature logs document the progression of cooling and the duration of standstill. Its monitoring readouts show the progression of EEG activity from normal to slowed to flat. Its procedural notes record the major steps of the surgery in the sequence in which they occurred. What it does not contain is a precise second-by-second log of every sound, every conversation, and every observation that took place within the operating room during the 6 or more hours the procedure required. That absence is not a product of carelessness. It is the ordinary condition of an operative record, which is designed to document the medical facts of the procedure rather than its incidental texture. The gap between what the record documents and what investigators needed it to document in order to resolve the Reynolds case precisely is not a gap that any future examination of the existing record can close. The record contains what it contains. The investigation has been as thorough as the available material allows. What it has produced is not a conclusion, but a carefully mapped territory of known and unknown, the documented neurological facts on one side, the documented account on the other, and the timeline questions sitting between them, still unresolved, still the center of every serious engagement with the case. The record itself, its pages of temperature logs and monitoring readouts, its handwritten procedural annotations, the accumulated notations of multiple investigators who have read it over the decades since the surgery was performed, continues to sit in the files at Barrow and in the case materials assembled by the researchers who have examined it most closely. It has not produced a final answer. It has not been superseded by more complete documentation. The annotations in its margins represent the careful thinking of people who took the questions it raised seriously enough to spend years working through them. Sabum's cross-references, Fenwick's notations, the responses of the surgical team members whose recollections are woven through the secondary literature, all of these are present in the accumulated record, layered over the original pages, adding detail without adding resolution. The disagreement between the investigators is documented in the same literature where the case itself is documented. It is a disagreement conducted in good faith between named professionals about questions that the available evidence has not yet been sufficient to settle. That kind of disagreement, held carefully and without collapse into easy answers in either direction, is how the case has persisted in the literature as something worth continued attention. And the record itself, its pages still there, still readable, still the same document it was when the first investigator opened it, continues to hold the questions it has always held, exactly as open as it has always been, and no more closed. In 1981, a small organization opened its doors in the United States with the specific purpose of treating near-death experience as a subject worthy of formal academic attention. The International Association for Near-Death Studies established a research archive, a peer-reviewed journal, and a framework for collecting and comparing accounts from people who had returned from the clinical boundary of life with something to report. The founding was not a dramatic event. There were no headlines. There was a mailing address, a membership roster, a filing system, and the slow accumulation of documented cases from hospitals and research institutions across several countries. What the organization created, in practice, was a place where a question that had existed for as long as human beings had survived serious illness could be asked in the same register as any other medical or scientific question, carefully, with attention to methodology, and without the need to arrive at a conclusion before the evidence was ready to offer one. The Journal of Near-Death Studies has been publishing peer-reviewed research since 1982. The cases it records come from cardiologists, anesthesiologists, nurses, neurologists, and researchers working at established universities. The accounts it publishes are cross-referenced against medical records where those records exist. Where they do not exist, that absence is noted. The journal does not endorse any metaphysical interpretation of the experiences it documents. It records what was reported, what was verified, what was challenged, and what remains unresolved. The Pam Reynolds case is among those it has cited. Her account, her neurological record, and the investigation conducted in its aftermath appear in the archive among hundreds of others, each one a folder of interview transcripts and operative notes, each one a question that was asked seriously and answered only partially, each one filed and kept. The archive itself has a particular quality when imagined from outside: shelves of case files organized by year, documents from the 1980s alongside documents from the 2010s, some folders thick with correspondence, follow-up interviews, responses from skeptical researchers, responses to those responses, some folders thin, a single account, a set of medical records, a notation that the witness could not be reached for follow-up. The Reynolds file sits among the others with no special marking. It is a folder. It contains what it contains. The question it holds is the same question the folder beside it holds, and the folder before it holds. What was happening, if anything was happening, in the interval between the last measurable signal and the first measurable signal, in the space the monitors showed only as a flat and silent line? Pim van Lommel is a Dutch cardiologist who spent years working in hospitals where cardiac arrest patients were regularly revived following resuscitation procedures. He noticed, over the course of his clinical work, that a significant number of these patients reported experiences they described as occurring during the period when they had no heartbeat, no blood flow, and no measurable brain activity. He noticed further that these reports shared consistent features across patients who had no contact with one another, who came from different cultural backgrounds, and who arrived at their descriptions independently. He designed a prospective study to examine this pattern with the rigor the question deserved. He enrolled 344 consecutive cardiac arrest survivors at 10 Dutch hospitals. He interviewed them within a few days of resuscitation before their accounts had time to settle into narrative. He followed up at 2 years and at 8 years. The study was published in The Lancet in December 2001. The Lancet study found that approximately 18% of the 344 survivors reported a near-death experience as defined by the study's criteria. A smaller subset within that 18% reported observations that appeared to correspond to events that had occurred during the period of clinical death. Observations of the resuscitation room, of specific procedures, of conversations they should not have been positioned to overhear. Van Lommel and his colleagues did not draw a metaphysical conclusion from these findings. The paper stated plainly that the experiences could not be explained by anoxia alone, nor by the effect of medication, nor by prior psychological factors, nor by fear of death, since these variables were distributed across the survivor population and did not predict which individuals reported an experience. What the paper offered was not an answer, but a more precise version of the question. The data had been gathered carefully. The question it refined had been asked honestly. The December 2001 issue of The Lancet, its pages now familiar to researchers who have handled it many times, remains in libraries and research collections around the world as one of the more substantial contributions to a scientific conversation that has been ongoing for decades and has not yet arrived at a shared conclusion. Raymond Moody's 1975 book, Life After Life, had established, years before Van Lommel's study, the basic vocabulary with which near-death experience research would organize itself. Moody, a physician and philosopher, compiled accounts from people who had been resuscitated or who had come close to clinical death, and he identified a set of recurring elements across those accounts: the out-of-body perspective from a point above the physical body, a sense of passing through a dark space, an encounter with light, the presence of deceased relatives, a review of the life that had been lived, a moment of choice or of being returned against preference. The list that Moody assembled was not offered as proof of anything. It was offered as a pattern. The pattern had been reported. The pattern was consistent enough to name. What the pattern meant was a separate question, and Moody was careful to keep it separate. When researchers began examining Pam Reynolds' account against Moody's foundational taxonomy, they found that her reported experience contained several of the elements Moody had cataloged. The out-of-body perspective was present. The encounter with deceased relatives was present. The sense of being returned against preference was present. What made her case singular within the broader NDE literature was not the phenomenological content, but the clinical context. The degree of neurological shutdown documented during her surgery was more thoroughly measured and more completely recorded than in almost any previous case. The flat EEG was not an inference, it was a printed record. The absent brainstem auditory evoked potentials were not an interpretation, they were a monitoring readout. The clinical baseline for her account was documented with a precision that most NDE cases, gathered retrospectively from patients whose neurological state during their experience had never been formally measured, simply could not offer. This is part of what has made her case a reference point in the research literature for more than 3 decades. It is not that her account is more dramatic than others. It is that the clinical documentation surrounding it is unusually complete. A researcher examining the case has access to a temperature log, an EEG record, a surgical timeline, and a first-person account that can be placed against each of these documents point by point. The alignment between the account and the record in some places, and the questions raised by that alignment in other places, have made the case the kind of material that serious researchers return to. The Reynolds file is cited not because it resolves anything, but because it holds the question with unusual clarity. Pam Reynolds appeared in the BBC documentary The Day I Died in 2002, more than 10 years after her surgery at the Barrow Neurological Institute. She sat in a chair with her hands in her lap and described what she had experienced in the same terms she had used in every telling since 1991. The bone saw that sounded like a dentist's drill, the case of blade attachments that reminded her of a socket wrench set, the conversation about the blood vessels in her groin, the vantage point above the table from which she observed the surgical team working. She did not embellish. She did not retreat. She described a specific set of events in specific language, and she had been describing them in specific language for more than a decade, without significant variation. The consistency of her account across multiple tellings, noted by several investigators who had interviewed her at different points over the years, was itself one of the details that made the case difficult to set aside entirely. The documentary reached an international audience. It placed her account alongside commentary from researchers, clinicians, and skeptics, allowing each position to be heard in its own voice, without one being used to defeat the others. The production approached the case as the BBC tends to approach things it cannot resolve, carefully, with attention to the specific claims, with interest in the range of serious responses those claims had generated, and without a conclusion reached before the filming was done. Pam Reynolds spoke about her experience without urgency. She seemed, in the footage, like a woman who had lived with a difficult set of perceptions for a long time, and had arrived at a quiet place with them, not a woman performing conviction, and not a woman seeking to persuade. The account simply sat there, as it had always sat, between what the monitors had shown and what she continued to describe. She died in May 2010, at the age of 53, from heart failure. The death was reported briefly in publications covering NDE research and in some general obituary notices. After her death, her account remained exactly as she had left it, unchanged, unretracted, still the subject of ongoing citation and ongoing disagreement. There was no final statement, no revision, no deathbed reconsideration. The record she had contributed to the literature was complete when she made it, and it stayed complete. The question it contained stayed open. Both of these things continued after she was gone, the same way the questions in the archive continue after the investigators who worked on them have retired, and the cases remain on the shelves without final notation at the bottom of the last page. The peer-reviewed journal Resuscitation has cited the Reynolds case in the context of discussions about awareness during cardiac surgery and during states of deep clinical unconsciousness. The citation appears in the context of ongoing research into what is known about consciousness, what is not known, and what the existing cases suggest about where the boundaries of current knowledge actually fall. Resuscitation is a clinical journal. Its primary readership is cardiologists, emergency physicians, and researchers working in critical care. The presence of the Reynolds case in its pages is itself a kind of statement about where the case stands, not in the fringe of paranormal literature, not dismissed as anecdotal, but placed in the working record of a medical field that is genuinely trying to understand what happens in the body and the mind at the extreme edge of clinical survival. Medical education programs at several institutions have incorporated the case as a teaching example, not as proof of anything, as an example of an open question. The way a good teacher uses a case that has not been resolved is to hold it in front of a room full of people who are learning to think carefully and ask them to say, with precision, what is actually known, what is inferred, what is assumed, and what remains genuinely undetermined. The Reynolds case, spread across a projected slide in a seminar room, offers exactly that kind of material. The EEG record is there. The operative timeline is there. The first-person account is there. The positions of multiple named researchers are there. The student who looks at all of this and says simply that it is interesting and that more work is needed is probably saying the most honest thing that can be said. The broader landscape of NDE research continues to expand. Studies conducted in the years following Van Lummel's Lancet paper have added to the dataset without resolving the core question. The AWARE study, conducted by Sam Parnia and colleagues at multiple hospital sites, placed visual targets on elevated shelves in resuscitation areas, targets that would be visible only from an elevated vantage point, and monitored cardiac arrest patients for out-of-body perceptions. The study produced inconclusive results, not because the methodology was flawed, but because the number of patients who both reported an out-of-body experience and were resuscitated in an area where a target had been placed was very small. The methodology was sound. The sample size of confirmable cases was not large enough to draw conclusions from. The study recommended continuation. The work continues. What the accumulation of this research has produced is not a consensus, but a sharper set of questions. The phenomena that patients report are consistent enough across cultures, across decades, and across clinical contexts to be taken seriously as a category of experience that requires explanation. The neurological basis for consciousness during states of clinical unconsciousness is not at this point well understood. The mechanisms by which detailed and accurate observations might be encoded and recalled during periods of profound brain suppression are not accounted for by any currently accepted neuroscientific model. These are honest statements about the state of the field. They are not claims about what the experiences mean. They are not endorsements of any metaphysical position. They are the place where the research taken as a whole and read carefully actually rests. Peter Fenwick, a British neurologist and NDE researcher who spent much of his career at the Institute of Psychiatry in London, has written that the Reynolds case is among the most carefully documented in the existing literature and among the most difficult to account for within existing frameworks. He does not, in his published work, claim that this difficulty constitutes proof of any specific alternative explanation. He claims that it constitutes a genuine problem for the conventional position that it is not enough to note that the brain sometimes produces vivid experiences under stress, because the documented neurological state during Pam Reynolds' standstill phase was not a state of stress-induced activity, but a state of measured and confirmed silence. The distinction matters to Fenwick. He returns to it in his published writings. It is the specific thing about the Reynolds case that he finds most resistant to easy resolution. There are researchers who find Worley's argument about anesthetic awareness entirely satisfying. They read the timeline and conclude that the most parsimonious explanation for Pam Reynolds's observations is that they occurred during a period of lighter suppression, during induction, or during a phase in which the EEG was slowing but not yet flat, and that the precise details she reported were registered by a partially anesthetized brain and then organized into a narrative that the waking mind placed, incorrectly, within the period of complete standstill. This position has logic to it. Anesthetic awareness is a documented phenomenon. The brain under deep anesthesia can register more than is commonly assumed. The temporal precision of a patient's post-operative account is not always reliable. These are real points raised by researchers who have thought about the case carefully and know the clinical literature well. There are also researchers who find this explanation unsatisfying, not because they are inclined toward belief, but because they have read the specific timeline and found that certain elements of the account, the femoral artery conversation in particular, appear to correspond to events that occurred at a point in the operative sequence when the anesthetic suppression was already substantial and the precise circumstances of femoral access were not anticipated or planned in advance. They note that the detail was not generic. It was specific. It involved a specific complication at a specific anatomical site at a specific moment in the procedure, and the person who reported it had been sedated and intubated before the surgical sequence began. This does not resolve the question. It simply keeps the question from being too easily set aside. Both positions are held by named credible professionals who have read the case carefully and reached different conclusions. The existence of this disagreement, sustained over more than 3 decades by people who know the medical literature and engage with it honestly, is itself a finding. It means the case does not yield easily to inspection. It means the available evidence is genuinely compatible with more than one interpretation and does not clearly favor one over the others. This is an uncomfortable place for a scientific field to remain, but it is where the Reynolds case, examined honestly, leaves the research. The question it embeds, whether awareness of any kind can persist during the complete cessation of measurable brain activity, is not a question unique to Pam Reynolds's case. It is a question her case makes unusually concrete. Most of the time, the question is hypothetical. In her case, it has a name, a date, a set of medical records, a drill identified by a woman who should not have been able to identify it, and a conversation overheard by someone whose ears were sealed with monitoring plugs and whose brain was showing no electrical activity at all. The case does not answer the question. It simply refuses to let the question be abstract. It holds the question down to a specific table, in a specific room, in Phoenix, Arizona, in 1991, and keeps it there. The city of Phoenix in 1991 is a particular kind of place to hold a particular kind of event. The desert light comes in flat and wide. The Barrow Neurological Institute sits in the broader medical district, its corridors quiet in the specific way that large clinical buildings are quiet, not silent, but stilled, the sounds of equipment and ventilation and footfall absorbed by the scale of the space and the purpose it is dedicated to. On the morning of Pam Reynolds' surgery, the building was doing what it always did. Patients were being prepared in pre-operative areas. Surgical teams were gathering and reviewing their protocols. The bypass machine was being checked. The monitoring equipment was being calibrated. The earplugs with their continuous clicks were being prepared for insertion. Nothing about the morning announced that the case being brought into the operating suite would still be cited in the research literature 30 years later. It was simply a morning in a hospital, preparing to do a very difficult and carefully planned thing. The flat line on the EEG monitor lasted for a period that has been estimated across various accounts and records at somewhere between 45 minutes and 1 hour within the broader surgical procedure. During that window, by every clinical measure available, the body on the table was not alive in any conventionally measurable sense. The heart was stopped, the blood was cooled and held outside the body in the bypass circuit. The brain was showing no electrical activity at the cortical level and no response to the clicks still being delivered to the sealed ear canals. The temperature of the body was approximately 60 degrees Fahrenheit, a temperature at which cellular metabolism is dramatically reduced and at which, by every conventional understanding of neurological function, the substrate that supports consciousness is not active. What Pam Reynolds reported from this window has been recorded, cross-referenced, disputed, partially confirmed, and left without a final resolution for more than 3 decades. The case is not solved. The case is not discredited. It sits in the literature the way the most difficult cases always sit, not resolved, not dismissed, simply present. The researchers who have worked on it have done honest work. They have disagreed with each other honestly. They have identified real problems with each other's positions and acknowledged real problems with their own. The question at the center of the case is the same question it has always been. No one has answered it. No one has established that it cannot be answered. The work continues, slowly, in the careful and unglamorous way that scientific work continues when the subject resists the kind of clear resolution that would allow the file to be closed. In the research libraries where the Lancet is kept, the December 2001 issue sits on the shelf with every other issue from that decade. It has been handled many times. The pages of Van Lommel's study are slightly worn at the edges in some copies, the data tables familiar to the hands that have returned to them. Near that issue, on the same shelf or on a shelf nearby, are other journals with other studies, other cases, other partial answers, and sharpened questions. The Reynolds case is cited in some of them. Her name appears in footnotes and reference lists. Each citation, a small acknowledgement that the case remains part of the conversation, that the question it holds has not been retired, that the researchers working in this field consider what happened in that operating room in Phoenix in 1991 to be relevant to what they are trying to understand now. The sky outside a research office window at the far edge of the morning has the particular quality of a sky that has been dark for a long time and is only beginning to admit the idea of light. The change is gradual. The dark does not end abruptly. It simply becomes slightly less than it was, and then slightly less again, the horizon holding the first pale suggestion of a color that is not quite blue and not quite gray, something between the two that belongs only to that specific hour. In an office where the Reynolds case file rests on a desk beside an open journal, where a pen lies across the margin of a page with a handwritten note in small letters, the window holds this light without announcing it. The room is quiet. The case is still open. The citation on the page is still there, the same as it was the day before and the day before that, holding a question that has been formally asked for more than 40 years and has not yet received a formal answer that satisfies the people who have studied it most carefully. The question does not require an answer tonight. It does not require one at any particular moment. It simply persists, the way the most honest scientific questions persist, not because no one has tried to close them, but because the evidence examined carefully by people of good faith on every side has not yet yielded the kind of clarity that makes closure possible. The Pam Reynolds case is part of a larger conversation that is still in progress. The conversation is being held in journals and at conferences, and in the careful back and forth of researchers who disagree and keep working. The file exists, the records exist, the questions exist. The people who hold them are still reading, still writing, still finding the question worth the attention it requires. The archive at the International Association for Near-Death Studies contains cases from before Pam Reynolds and cases that came after her. Some of those cases are more recent. Some involve cardiac arrest patients at hospitals, where monitoring technology has improved since 1991, where the clinical record is even more detailed, where the neurological state of the patient can be documented with greater precision than was possible during the early years of this research. Each new case is a new instance of the same old question, asked in slightly different clinical circumstances, with slightly different documentation, producing slightly different details that add to the overall pattern without resolving it. The pattern continues to be consistent in certain ways and inconsistent in others. The consistency is noted. The work of making sense of both goes on. Pam Reynolds, the singer-songwriter from Atlanta, who was 35 years old when she was diagnosed with a giant basilar artery aneurysm, and who was told that the only way to remove it was to stop her heart and cool her blood and drain the fluid from her brain. This specific woman, with a specific voice and specific hands and a specific notepad on her kitchen table with a name and an address written at the top, contributed to this ongoing conversation, something that could not have been anticipated when she first sat in a neurologist's office in 1991 and tried to understand what she had just been told. She contributed a case with documentation, a case with a flat EEG and a pneumatic drill, and a conversation about blood vessels at the femoral artery, and a vantage point above the table from which all of it was reported to have been observed. The case is in the record now. It has been there for more than 30 years. Outside, somewhere, the long night continues, or the long day begins, depending on the hour at which these words are heard. The research libraries are still. The journals are on their shelves.